everyone, welcome to Visual Physio.
A quick honest question. Have you ever read right MCA infarct on a patient's chart and just nodded while internally panicking about what that actually means for your assessment? Yeah, me too. So, today we are fixing that for good. We are breaking down stroke, its definition, the types, the warning signs, and the three vascular syndromes that show up in almost every exam paper and almost every neuro ward, which is ACA, MCA, and PCA syndrome. By the end of this video, you'll be able to look at a stroke case and immediately know which artery is involved just from the symptoms. So, let's get into it. So, what actually counts as a stroke? The WHO defines it as a sudden disturbance of brain function of vascular origin that either lasts more than 24 hours or leads to death. Notice the 24-hour cutoff. That's the line that separates a stroke from a TIA, which is a transient ischemic attack. Same symptoms, but a TIA resolves before that 24-hour mark. Examiners love asking this, so lock it in. Now, why does a stroke happen? There are three main culprits. So think of your blood vessels like pipes in your houses. Hemorrhage, the pipe bursts. Blood leaks where it shouldn't. Embolus, a clot forms somewhere else in the body, travels through the bloodstream and gets lodged in a brain vessel. Thrombosis, the clot forms right there inside the vessel, usually on top of plaque buildup. Risk factors fall into two buckets, the ones you can change and the ones you can't. Those are modifiable lifestyle ones like smoking, obesity, lack of exercise, poor diet and excess alcohol, stress. Under modifiable medical ones, hypertension, atrial fibrillation, dyslipidemia, diabetes, a prior TIA, sleep apnea comes. And under non-modifiable, factors like age, gender, race, and family history comes. As physios, this matters because a huge part of stroke rehab is also patient education on the modifiable side. We are not just treating the deficit, we are preventing the next one. If you only remember one acronym from this video, make it this one, which is B FAST. So what is this? B means balance, sudden loss of balance or coordination. E refers to eyes, sudden change in vision. F is face, drooping on one side. A is arms and legs, include sudden weakness. S is speech, difficulty speaking or understanding. And T is time, which says call emergency services immediately. Time is brain tissue. Every minute a stroke goes untreated, neurons are dying. So if you ever spot these signs in a patient or in a relative anywhere, don't wait it out. Call for help immediately. Okay, now for the part you are really here for, the vascular territories. There are five major ones: anterior cerebral artery, middle cerebral artery, posterior cerebral artery, internal carotid artery, and vertebrobasilar artery syndrome. Today, we are tackling three of the big ones: ACA, MCA, and PCA. ICA and vertebrobasilar are coming in part 2, so make sure you subscribe so you don't miss it. Now, we'll move on to anterior cerebral artery syndrome. The ACA is one of the terminal branches of the internal carotid artery and it's involved whenever you see this pattern of symptoms. Here's the key fact that unlocks everything about ACA syndrome. It supplies the medial surface of the brain and that's exactly where the leg area of the motor and sensory cortex lives. So remember this line, ACA is equal to leg. For example, a right ACA stroke gives you left lower limb weakness and sensory loss. It's simple as that. Now the question is, why symptoms may be mild? Here's a question that trips people up in vivas. Why do some ACA strokes barely show any symptoms at all? Because the ACA has a backup route, a collateral circulation through the anterior communicating artery. So if the blockage is proximal, before that junction, the brain can reroute blood and the deficit might be minimal. But if the blockage is further down in the distal branches, there is no backup left and the deficit is much more serious. Location of the clot literally determines how bad the stroke looks. For signs and symptoms, what do you actually see clinically? Those are contralateral hemiparesis, mainly in the lower limb. Upper limb is relatively spared. Then contralateral hemisensory loss. Same pattern, leg more than arm. Urinary incontinence, apraxia, abulia, slowness, delay. Basically, the patient seems mentally stuck. And here's a channel's go-to memory trick. Picture a little stick figure spelling out MA. The A at the bottom represents ACA and it controls the bottom half of the body, the leg. We'll come back to the same figure for MCA, so keep that in mind. Now we'll move on to middle cerebral artery syndrome. This is the one you'll see most often in clinical practice, that is MCA syndrome. This is the most commonly affected vessel in stroke. MCA supplies the lateral surface of the brain, the frontal, parietal, temporal lobes, the primary motor and sensory cortex, Broca's area, Wernicke's area, optic radiation and the internal capsule. That's a lot of real estate, which is why MCA strokes tend to be the most dramatic. Since MCA covers the lateral cortex, it's the face and arm area that's most represented here. So if ACA is leg, MCA is face and arm. For example, a right MCA stroke gives left face and upper limb weakness with the leg relatively spared. So this is completely opposite pattern from ACA. Now, MCA also covers the language centers. So let's talk aphasia. And this is a classic exam favorite. Broca's aphasia, where it includes non-fluent, slow, hesitant speech, but comprehension is okay. Think they know what they want to say, but they just can't get it out. Wernicke's aphasia, the opposite. Fluent, normal sounding speech, but it makes no sense and comprehension is impaired. Global aphasia, both production and comprehension are affected, the worst of both worlds. Other deficits includes limb kinetic apraxia, contralateral homonymous hemianopia, loss of conjugate gaze to the opposite side, and ataxia of the contralateral limbs. So here's your one-line memory. MCA syndrome is face plus arm plus speech plus neglect plus visual field defect. Back to our stick figure. Now the M on top lights up. M for MCA, controlling the upper half, which is face and arm. Now we'll move on to posterior cerebral artery syndrome. This is the last one for today, PCA syndrome. The PCA mainly supplies the medial and inferior surfaces of the occipital and temporal lobes, plus the upper brainstem, midbrain, and most of the thalamus. Notice this is a completely different territory from ACA and MCA, which is why PCA strokes look nothing like the other two. Because PCA supplies the occipital lobe. Your visual cortex, visual symptoms are the hallmark of a PCA stroke. And just like ACA, if the occlusion is proximal to the posterior communicating artery, collateral flow can keep the damage minimal. So the features includes on the peripheral territory side, you get contralateral homonymous hemianopia, bilateral hemianopia with macular sparing, visual agnosia, which is can't recognize objects by sight, and prospagnosia, which you can't recognize faces. Then dyslexia without agraphia, can't read but can still write. Then memory defects. On the central territory features includes central post-stroke thalamic pain. So spontaneous pain and abnormal sensations will be present. Involuntary movements like chorea, intention tremor, hemibalismus, then contralateral hemiplegia, Weber syndrome, where oculomotor nerve palsy plus contralateral hemiplegia will be present. Then paresis of vertical eye movement, slight miosis, ptosis will be present. A one-liner. PCA syndrome is visual problems plus thalamic pain plus memory loss plus midbrain signs. And back to our stick figure one more time. Its eyes turned red. Red eyes for PCA because vision is the signature feature. Let's bring it all together with our stick figure. M on top, MCA, face and arm. A on the bottom, ACA, leg. Red eyes, PCA, vision. Next time you see a stroke case, just ask, is it the face and arm? Think MCA. Is it mainly the leg? Think ACA. Are visual symptoms front and center? Think PCA. So that's it for part 1. In part 2, we'll cover the two we didn't get to today, ICA syndrome and vertebrobasilar syndrome. So hit subscribe and turn on notifications so you don't miss it. If this helped clear things up before your exam, drop a like and let me know in the comments which syndrome used to confuse you the most. See you in the next one. It's your Flo signing off.